All right, welcome everyone to this webinar from EVRS. We would like to welcome you all to our webinar here and our guest speakers, and I would like to welcome my friend and the co-moderator, Dr. Gianpaolo Gini, and it's Ahmed Salam here from Arkansas. Dr. Gianpaolo?
Hello everyone, thank you Hamid. I'd like to thank the panel. I'd like to thank all the friends at home that will be tuning in and following this webinar. I'm sure that the expertise of the panel members will be of interest to not only the more accomplished surgeons, but to the ones that have a bit less experience. This is actually the second of a number of webinars, a series that the European Vitreoretinal Society is planning to carry out. The first one was about a month ago, and it concerned the primary retinal detachment. Now, for those of you that missed it and are interested in catching up, you can obviously access it through Facebook, YouTube, and other social media. I think we should be spending a few words about the European Vitreoretinal Society, which is sponsoring today's webinar, and which I am privileged to serve as president. The name European Vitreoretinal Society, or EVRS for short, is actually misleading today because it started as a European idea, but it has stretched beyond Europe, and it has now reached, I would say, all four corners of the world. We have around 900 members representing 85 different countries. And the focus of EVRS has always been on education, and it's always been about making better surgeons to get an improvement in patient results and patient care. And this was done essentially through three main approaches, one of which was the website, which is a very rich website which has videos and presentations which are educational in purpose. The other one being the European Vitreoretinal Training School, which some of you have honored us to come as teachers. And the third one, obviously, is the annual meeting, the European Vitreoretinal Society's annual meeting, which unfortunately, like many other societies, could not take place this year. But you see, the philosophy that has always been very peculiar to EVRS has been that of learning peer-to-peer. So generally, what I'd like to say is that we have a horizontal way of learning so that we learn from each other rather than the more classical vertical top to bottom learning process, which generally involves someone giving a lecture and the others just listening in a very passive way. Now, this, if you think about it, 20 years ago was quite a revolutionary concept, and it probably is today. It's quite innovative today as well. So to make the long story short, these webinars will be available on a regular basis. We have more in program, and they will go all the way to our next meeting, which will be in June next year. Hopefully, physically, we will all be able to attend, and this will be in Verona in June, and exactly as we have done in the past. So that's all I have to say, and I hope this meeting will be interesting for everyone. Ahmed, please.
Thank you so much, Gianpaolo. So I would like to welcome all. For the sake of time, we move on quickly. So Dr. Fayyad is from Jordan. Thank you so much for joining us, Dr. Faisal Fayyad. And then
thank you for the opportunity. Thank you. Thank you very much.
Thank you so much. And then Noor Akar, she's our EVRS member, and she's on the board from Turkey. Noor, I know it's late for you. Thank you so much for joining us.
Thank you. It's my pleasure.
And it's late for Dr. Fayyad. It's 10 p.m. And then Lukan Mishev from Bulgaria. Thank you so much for joining us. I know it's late as well, 10 p.m.
Thank you for having me here.
Thank you so much. And then last but not least, Dr. Carlos Matiu, our friend from Spain. Thank you so much, Carlos.
Thank you very much.
That being said, we'll start the video. So, Carlos, please, I got your presentation here.
Okay, let's go. Thank you very much, Ahmed, Gianpaolo, dear friends, Lucan, Faisal and Noor. I'm going to speak about my steps and tips. In vitreoretinal surgery is not black and white. You have your experiences and you deal with things in different ways. But I'm going to speak my way to deal with patients with PVR. I divide this in some chapters. First, it's scleral buckle in PVR. I always use scleral buckles. Time consuming, bloody, but at the end, in PVR cases, you have a anterior-posterior contraction and also you have a circumferential contraction. If you cut the retina, if you think that only cutting the retina is good, you have to think that you have 3 circles here. A, B, and C. A is smaller than B, shorter, and B is larger than C. When you cut the retina in A, the retina is going to be in B, then, it's not a relaxed retinotomy. In fact, you're putting the retina in a larger circumference. And the buckle works like this, reducing B just to make the retina more comfortable to be there. I tried to find the best case to show this. This is many years ago. This was 20 gauge, but it was a giant retinal break with a PVR. And look at this. I didn't remove the membranes. I only tried to, default this case, this giant retinal tear. And only with this, I could leave the retina in its place. Then, of course, I'm going to remove the membranes, the ILM, I'm going to speak about it and put silicone oil. Of course, you can have membranes after this, but, the border, the break is supported by the buckle. Okay, remember, in retinal detachment, even with no subretinal or epiretinal PVR, retina is rings. And of course, even more with PVR. Remember this guy, Robert Hooke, 17th century, contemporary to Isaac Newton. They didn't get along together very well. He explained the Hooke's law of elasticity. And at the end, you will be very good to removing the membranes, but at the end, you are doing nothing to have the retina against towards the eye wall. Then here is the buckle to help you to maintain the retina attached. Chapter number 2. Visualization is an important key. In some cases, these patients are pseudophakic, and as you can see, I put my buckle there. I strongly recommend don't try to break the posterior synechiae, cut the anterior capsule and trim it if you can trim it, these white areas, trying to improve your visualization because, visualization is a key. You have to see perfect the membranes, as you can see in this case, perfect the membranes to peel them and to have a good result. Again, another case showing the same. You see there is a synechiae there into the right. Then I don't touch the synechiae. I cut the capsules there and look at this. This is the visualization I can obtain. But in some cases, it's so difficult, these lenses. And then some surgeons, they prefer to remove these lenses. I prefer not to open the anterior chamber, never in these kind of cases. Then the thing I do is to, dislodge the lens, disinsert the lens, I clean the capsules, I remove everything, and I suture the lens to the iris, as you can see here, using a mechanical technique. And then you can see a perfluorocarbon liquid, and you can see how I peel the membranes, etc., as you can see here. Let me show another case, more complex case. In the next case, you not only have a meiosis, but you have the lens terrible. Then the thing I do is I dislodge the lens, I disinsert the lens, and I clean everything. I clean the capsules, but I don't try to remove the lens from the eye. And I will explain you why. Then I clean everything. I put eye retractors in this case, and then I put perfluorocarbon liquid. I stain. I'm going to spray this, and then I remove the membranes with an excellent visualization. That is the only thing you need. Excellent visualization to see the membranes and to do a great job. Look at this. This also there are subretinal membranes. I remove the subretinal membranes, and at the end, I'm going to suture the lens to the posterior surface of the iris. I'm going to show you now. And this has one advantage for me, because you are approaching the lens to the posterior surface, and then you are closing the gap between the lens and the posterior surface of the iris. That is the space where the silicone oil pass to the anterior chamber. Then you are closing this space. But let me tell you, when a patient is phakic, the thing I prefer to do, and I understand that many surgeons, they do, phacoemulsification. I prefer to do lensectomy. As you can see here, the iris doesn't move, and you will have an impressive visualization. At the end, you decide. You keep the posterior capsule, you do a capsulotomy, or you leave this for a secondary IOL. Chapter number 3. The chapter number 3 is about the staining membranes.
Carlos, can I interrupt you for a second?
Absolutely.
So my question is everything is very beautiful. My question is, let's say you're planning a big retinectomy, nearly 360 because of the situation. Would you still go ahead and put a buckle?
Yes.
We're going to do a retinectomy nearly.
Yes. If the case is so bad, perhaps I would not do it. But in regular cases where I'm not sure, because again, if you cut the retina 360 degrees, the retina is going to be to a larger circumference, and you will tell me, okay, why don't you do radial cuts? And my question to you is, to where? Where you are going to stop, because the retina is going to a larger circumference, and then the retina is not relaxed. Then you are going to put a lot of nails there. Then if you put a buckle, you don't need to be in the top of the buckle. You reduce the circumference also in the the posterior part of the buckle, and I think it helps you to maintain the retina attached. I definitely I use buckles much more than I think the majority of vitreoretinal surgeons. And if the patient, tell me.
I totally agree with you.
Great. I'm not used to this. My friend.
But generally, I think you'll all agree that generally, at least as far as I'm concerned, I'm so concerned with the retina that I forget to possibly the usefulness of a buckle. So I will use a buckle maybe at a second instance when I do have reproliferation. And I put a buckle in. But the idea of putting a buckle in the first place, especially because of the different diameters you're talking about, is absolutely correct. And I think we should, in particularly severe cases where we are anticipating a 360-degree retinotomy, I think this should be considered as a very serious option.
So Dr. Carlos, back to you in a second, but Dr. Fayyad, do you do, so in PVR surgery, do you always consider encirclement as well?
I never regretted that I have a buckle.
Right.
I never regret that.
Right.
But I must admit, I don't put it all the time, but often I do. And I never regretted a scleral buckle around the eye once I start my vitrectomy.
Right. And Lucan, do you, let's say you're not anticipating 360 retinectomy, just to make it easy, would you use a buckle as well and encirclement?
No, I don't use buckles at all.
Okay. And Noor, where is Turkey here?
I mean, of course, buckle is my first choice in a PVR detachment.
Okay.
But at the end, sometimes I start with a buckle but end up with a retinectomy. So if I do 360 retinectomy, I just get out of the buckle, of course.
Yeah.
There's
all right. That's great. Carlos, back to you. Chapter 3.
Okay, let's go. Stain the membranes. I know you're very experienced with membranes. Look at this, lensectomy. Believe me, it's the best way to see. We are going to look at the iris, doesn't move. Then we are going to remove the lens. It's very important that you polish the posterior surface. And then I stain the membranes, putting air in the eye. Why? Because I stretch the retina. And then the membranes that are inside the fold sometimes, I can stain better, and I can have a better staining to see better the membranes. Then I put this, I aspirate through the hole. Look at this staining. You can see all the membranes. Let's see another case. This is a case, this is a primary PVR. This is not previously operated, but I put the buckle first, of course, then I aspirate through the break. Look at the retina. It's stretching the retina and the folds are opening. Then you put one drop, and you are staining all of these membranes, and then you remove the excess of dye, and then perforate carbon liquid. I'm going to speak about it. I always peel the membranes under perforate carbon liquid. Look at this. Why? Because it helps you as a third hand. It maintains the retina attached or almost attached, counteracting your forces, pulling forces when you are peeling the membranes. And I always use perforate carbon liquid. It's faster. I think it's really better. Then at the end, you do laser around the brakes, and that's all. Look at the other case I showed you before. Look at this, the membranes. These membranes were so adherent that, sometimes I need, bimanual surgery to peel these membranes. Fortunately, with the perforate carbon liquid, you try first. The most important thing is try not promote breaks in the retina. Because of the perforate carbon liquid, don't worry about the perforate carbon liquid. The problem is to have, breaks in the retina that is so stretched and so, it's wrinkled because of the PVR and the retinal detachment. You don't have rush. You don't have to be running, and then you see the membranes, and one by one you're removing all of these membranes out from anterior to posterior, or posterior to anterior, whatever you prefer. And look at this. Very important, the mid periphery. Mid periphery is the worst place. Okay, this is chapter 5. Let's go. Sometimes you have to improvise. Look at this. This is a case that was sent to me 3 months ago. And then at the end, the patient has had this terrible hole down. I put a buckle, of course, but also a macular hole. Then if you stain here, all the dye is going to be under the retina. Then I put perforate carbon liquid, first air, then perforate carbon liquid, and I stain under perforate carbon liquid, and I put an ILM inside the hole, as you can see here. Then you have to improvise and to change some techniques, during the surgery. Chapter 5. In chapter 5, do not leave the ILM behind. Peeling as large as possible. Look at this is a PVR case. I aspirate through the hole, then I complete the vitrectomy, look at the buckle, and then I put some, drops over where I think the membranes are. Then you see the membranes, and then you go there, be careful mid-periphery. Be careful because the visualization in mid-periphery is not that good. Then you go, no rush, and you peel all the membranes you see. And then you are going to see how, this is the mid-periphery. In the macular area, I always go with my central, contact lens that, the view is absolutely amazing. Do you think that they remove all the ILM? I re-stain. You will see now. For me, it's very important you don't leave any ILM in the macular area. And if you try to remove much more, very important in the inferior arcades and larger than this. Look at this. This is a part of internal limited membrane. It was to be left in this place, and my advice is try to remove as large as possible the internal limited membrane, as you can see here. If you can do it larger to the inferior quadrants where the PVR recurrence of PVR will be more frequent, try to go more peripheral in these kind of cases. You can see here, this is the inferior temporal arcade, and I go up. When you pass the arcades, to remove the ILM is much more difficult, as you know. Chapter 6. Retinectomies, last resort. Once in a meeting, they asked me, "It's better under perforate carbon liquid or under air?" I say, "Air. Don't do it under air. Air pushes the retina towards the RP. And then when you are aspirating, the retina becomes attached, and it's very difficult to cut. And if it bleeds, as this case." I was not performing at that time, the retinectomy, but, it bleeded. And then, where the blood goes, to the macular area, to the posterior pole, of course, because the retina is detached. Look at this, the peripheral retina is attached. Then use perforate carbon liquid. I usually don't do diathermy, but, trying to be very academic, I did diathermy in the big vessels. But, I rarely do diathermy. I go as anterior as possible. Here, there were a lot of laser, then the retina here is between attach and detach. It's so difficult. Then you have to go in an area that is fine. Look at this. Be careful with infusion cannula. When you are like this, cutting the retina, be careful. The cannula has to be horizontal, not towards the surface of the perfluorocarbon liquid, because it strikes the surface of the perfluorocarbon liquid, and these bubbles will form, and then they can enter in the subretinal space, and you can end with a subretinal bubble. You know, in summary, these are my steps, and I understand that, you know, not everybody do the same, but, you know, these are my main steps. I use buckles in the majority of cases. Majority means more than 96, 97% of my cases. Improve your visualization. Lensectomy is a good thing. In posterior PVR, you can use only phacoemulsification. It's great. But your lensectomy in complex cases is the best technique. Beginning anterior PVR, if there is a complex anterior PVR, stain membranes, I recommend stain membranes because you can see them, but it's better with staining. Posterior PVR under perfluorocarbon liquid, remove as much as possible the ILM, and retinectomy is the last resort, and try to do it as peripheral as possible. And that's all, my friends. That's all I want to share with you. There are many other things, but, you know, these are my points.
That's a lot, Carlos. Thank you so much.
Thank you. Thank you.
So, Carlos, there was a question about the viewing system. I know you use a contact lens viewing system. And what's your illumination? Is this wide-angle light or
the light? You mean the light?
The light. What's the light?
Let me tell you one thing about the lights. In these kind of cases, I always have a chandelier. That's right. But if you want to see the vitreous remaining, focal lights are the best. You know, compare a laser light towards a normal light. You know, focal lights are better than I use to record or something like this. I use chandeliers, but focal lights, in my opinion, are better to perform vitrectomies.
Okay, Dr. Fayad, do you want to start putting your presentation up? If you start, please, to upload. Question here to the panel as Dr. Fayad is uploading. That's from here.
There's so many topics that you touched, Carlos. Maybe we could ask the panel. I see that you have this interest, obviously, maintaining the lens, and even the fact that you are maintaining the anterior capsule. Now, that is to separate, I imagine, to contain the silicone oil you'll be putting in the eye. Is that correct?
Yeah. Yeah, absolutely. I want to have a barrier between them. But, you know, the topic of the silicone oil, I think when we arrive to silicone oil, we have to discuss this, how to avoid, you know, silicone oil to enter in the anterior chamber. Because even with the anterior capsule, even with a lens sutured to the iris, at the end, it's very important to avoid the silicone oil entering the anterior chamber.
I did see that you had a 6 o'clock iridotomy performed.
Yes, absolutely. I always do it. Yeah,
that we believe is probably the main.
Sure. Yeah. But the second thing is, don't leave the eye at the end of the surgery with the silicone oil. Don't leave the eye with higher pressure than the patient can maintain. Imagine that you have a 3 millimeters of mercury PVR, and you leave the eye at the end of your surgery in 30. You know, silicone oil at the end will arrive in the anterior chamber, because who maintains silicone oil in the vitreous cavity is the aqueous humor. If the patient does not doesn't produce aqueous humor, you can do whatever you want. Retention sutures, lenses, anterior capsule, whatever you want. Be careful with the pressure. Is the thing.
Right. Thank you so much, Rafael. You're up. Thank you.
Can I ask one question, please?
Please, go ahead, please.
Dr. Mateo, about the iridotomy, when you use a heavy silicone like HD or Densiron, do you change the position 12 o'clock, right, of the iridotomy?
Absolutely, yes. And I use a lot heavy silicone oil in PVR cases.
Yeah.
So that's a great question. So for the audience, if you're using heavy silicone oil, we put the iridotomy up. And always consider iridotomy if there's no complete capsular support. But if you have an intact capsule, you don't need an iridotomy, or if you fake it, you don't need an iridotomy. Thank you.
Thank you. You see my screen?
Yes, sir.
Yes.
Yeah, okay. First, I would like to congratulate everyone for this fantastic webinar. Thank you, Carlos. You summarized the PVR in all its aspects. This is my first case. This is a 48 years old man with dropped cataract inside the vitreous cavity. I placed the buckle first. I could not see epiretinal membrane, just subretinal strands, and this is my way to do it. You see, you can see even the optic disc. And here, before I do almost complete vitrectomy before taking the lens out. As you can see here, those are small holes at the periphery of the retina, inferotemporal, and here I'm using the fragmatome from other opening. I'm doing 25 gauge vitrectomy in this case. Here I remove the lens. You can see the subretinal fibrosis. And I don't do posterior retinotomies. How I tackle these cases is by doing very peripheral retinotomy, regardless where the subretinal fibrosis is. Even if it's just localized posteriorly, in my opinion, there is a big chance of reproliferation of PVR if you go and do posterior retinotomies. While if you go anteriorly, the PVR recurrence is much less, and this is my approach. Of course, I always use chandelier light, but as mentioned by Carlos, by doing focal vitreous, if I had to remove it, I can see it with the chandelier light. I have to point the vitreous. This is what Macmer told us, point the enemy with the pipe light. He meant that, point the vitreous. And this is, I do it. You can see the preplaced buckle. And this is the retina flat in the retina with all the membrane is gone. I'll go for my second case.
Dr. Fayad, quick question.
This is, yeah, okay.
Where do you usually
yes, please.
chandelier? What, do you put it inferiorly or infranasally?
Sorry?
Where do you usually put your chandelier?
The chandelier, I put it usually at 12 o'clock, but this is, I mean, it depends. I mean, if I have, it is, sometimes I put it temporal side, sometimes nasal side, but mainly I put it superiorly.
Right, thank you.
Faisal, I want to just remark what you said about posterior retinotomies. I totally share your point of view, because posterior retinotomies you don't want to perform because it's very vascularized, the retina posteriorly. So anterior retinotomies and retinectomies are obviously better. Does everybody share that viewpoint? Because this is something that comes up in primary retinal detachment as well. A lot of people do posterior retinotomies, and I'm not sure it's the right thing to do. What do the rest of the panel think?
This is because the perfluorocarbon liquid is very expensive. This is the main reason, because, you know, perfluorocarbon liquid is a great thing to use. And I think, you know, I think Faisal showed impressive images removing these subretinal membranes. I agree totally. And try always in the periphery, never the posterior bulb. And about PVR, re-PVR, laser, you know, it's a crazy, in my opinion, it's a crazy thing. I think it's perfect to do in the periphery.
Yeah, I was surprised at the AO a couple of years ago. I was attending, and most of the participants were the pre-academy meeting. They were for posterior retinotomy. I think posterior retinotomy, I mean, belongs to the last century. Yeah. I think we have to move anteriorly. I mean, retinotomy has to be very anterior. You have better tamponade first, and you have less incidence of PVR. I'm not for equatorial or posterior retinotomies at all.
Faisal, let me tell you only one comment. Let me tell you one thing, because I saw you peeling the membrane, the subretinal membrane, wonderful. And one trick is, because when you grab the membrane, you pull it, you have the two sides of the membrane that they go to the other place. Then one trick is to grasp the membrane, to put the other forceps like a ring around it, and then you begin to pull, but the membrane cannot break the retina around it. I don't, like a napkin or something like this.
Absolutely.
And then you avoid,
Yeah.
Then with two forceps, as you showed with two forceps, is you make around it and you pull it, and the membrane has to go inside the hole, and you avoid to break more retina. It can help in some cases.
Yeah. I agree. Yeah. In the other hand, once you pull the membrane through the hole, once it's posterior, you might enlarge the hole big time. You start with a smaller break, a small hole, then it becomes very large once you peel it.
Yes.
This is other problem by doing posterior retinotomies.
We just have a few questions from the audience, so if you can just get some out of the way. Maybe a question here for Dr. Faisal. Do you always remove if you do a retinectomy, do you remove the anterior retina? I know you try to do it as anterior as possible, but if you happen to, I'm sure we'll see more of a retinectomy's videos, but do you remove the anterior retina?
Of course. Yeah. If it's not very peripheral, I absolutely remove it. And just as was mentioned by Carlos as well, if I do it very anterior, I don't have to use endodiathermy. If I have to do it, as some videos that we'll see later on, of course, I have to do diathermy, otherwise there will be bleeding. But of course, all anterior retina, it has to be removed.
I think the only maybe exception, if you agree, and I think Carlos may agree, is that when it's very adherent to the choroid from previous laser and it's all very adherent, sometimes you have to leave it because it's going to be bleeding and causing issues. So I think it's a balance thing.
But Hamid, that retina will not be affecting you anyway because that retina has been lasered already.
Yeah, so that's a very good point, actually.
It's as if it weren't there. It's the retina which is fresh and not tied to the choroid.
Absolutely.
Get rid of.
That retina is an infection. It is scar. It is a scar.
Yeah.
You do that with indentation because most of the patients are either pseudophakic and it's easy to reach the anterior retina with indentation.
Yeah. No, Gianpaolo, thanks. That's actually a great comment. Dr. Fayyad, please go ahead. You got your second video there.
I can't hear you, Gianpaolo.
No, we're saying, yes, please go ahead with your second video, Dr. Fayyad. Please go ahead.
You can start your video, Faisal.
Yeah. I can't hear you guys.
You can go ahead with the video.
Okay, thank you.
All right, thank you. You can hear us now.
Sorry.
Yeah, no worries.
This is this is my second case. This is 19 years old young man. He was referred from Baghdad. He had the previous multiple surgeries, but the retina was stretched. I could not find enough laser hole, but here I am peeling under silicone oil. Maybe someone agrees with me, maybe no, but I prefer usually at the beginning to peel under silicone oil because the retina is stretched. And here I removed the silicone oil. I continued peeling, and as you see, there are posterior retinal breaks, a lot of laser, but the retina is foreshortened. In this case, there is previous scleral buckle as well. And you can see here, there is epiretinal membranes. And the big fault of the previous surgery was that this patient did not have ILM peeling as well. Maybe some of the membranes were left, I have no idea. And you can see here, I'm peeling first without dye because I can see that. And trying to free the retina. You can see there is iatrogenic retinal break while I am peeling. As mentioned by Carlos, just do the ILM peeling as far as you can. And here I'm using the diathermy because there are blood vessels. There are blood vessels that I had to do diathermy in order to cut the retina. In this case, this what was mentioned by Gianpaolo, that you cannot go anterior and remove all the retina. That is scarred retina. It's not mandatory to remove that piece of the retina because there is a scar there. This is the retinotomy that I did. I thought it was enough. Of course, you have to clean the subretinal space. Here, the subretinal space is cleaned, and here how the retina looks like at the end of the case. You want me to continue?
Yes, please. Please go ahead, Dr. Fayad.
You hear me?
Yes, please go ahead.
Yeah, you want me to go ahead, okay?
Yes.
This is a case that I did just recently after the invitation. This patient presented to me, 28, I think, or 30-something years old, young man. He had a previous cataract surgery. I have no idea why. And this is at his presentation that how he looked, how this retina looked like. This is 3D, but I converted it to 2D. Here I start in peeling the membranes. You can tell where the membranes are because you can see the anatomy, the architecture of the retina. And you can see here there is severe PVR in this case. And here I'm injecting dye. Then I'm here using Helon. Why I'm using Helon? Because in my opinion, if you use heavy liquids, the heavy liquids will run out from this tunnel, from this cone underneath the retina. While if you inject Helon or any product like Helon, there is no problem. You can see also there are other tears on the nasal side, not just the giant retinal tear on the temporal side. Here there is a way that I like very much in peeling the PVR membranes, which is bimanual 2 forceps technique, because I can hold the PVR membrane with the one hand, switching my hands in order not to come in and go out from the eye very often. And this is how I do it. This is all under Helon. And you can see how I do it. This is, the retina is attached to the retina through PVR membrane. And here I'm using a hook as well, because in small spaces, I trust it more. And here I switched to heavy liquids, from Helon to heavy liquids. Under dye, I see the membranes cleaning the subretinal space. There are some pigmented membranes underneath the retina. I try as much to preserve the anterior edge of the tear, to conserve the retina as much as I can. That's why I peel at the edge of the giant retinal tear. And this is after heavy liquids. the ILM was peeled, and the retina is completely flat.
This is so beautiful. Looks very beautiful, Dr. Fayad. A difficult case, really. Very difficult case.
This is actually 4 hours case. 4 hours case. Maybe in hands of Carlos, maybe half an hour.
20 minutes.
I think, if I can say, I think you made such a good point. I too use viscoelastics to open up funnels. If you don't use viscoelastics, the funnel will just tip over with the heavy liquids, and you just get heavy liquids beneath the retina. It's the same concept that you can use also in diabetic retinopathy. It's the viscoelastics really give you a great chance to open up these membranes. So it's an excellent point. Excellent point.
Impressive surgery, Faisal. Impressive. The only one more thing is the advantage to use in these kind of cases viscoelastics is to explore the posterior retina, because some of these cases have posterior breaks. And then if you inject perfluorocarbon liquid, it's going to go through the break. Then, use in these kind of severe cases to explore the posterior retina helps you. It doesn't attach the retina, only opens the balloon, but it doesn't attach. Perfluorocarbon liquid attaches the retina, but Visco opens the balloon. Impressive surgery, Faisal.
Very good point. Thank you, Carlos. Thank you. Thank you.
I have a slight comment here about viscoelastic. I think the first thing that one shouldn't do is to relieve the funnel from the periphery. So if you are not early with your retinectomy, you can open the funnel with PFCL. Somehow in my hands, the surface tension on Hilon GV5, whatever you want as a cohesive visco, wouldn't do the job of opening the funnel. But if you keep the periphery, there is no way this funnel to tip from the PFCL. So early retinotomy can lead to tipping the funnel.
I don't really do early retinotomy. I don't do it, otherwise you put yourself in trouble in peeling, and you don't know where the retina should stay. I leave the retinotomy until the end, once I am sure that the retina is at the right place.
So how in your case the retina was already cut?
It's not. I cut it at the end, once I was sure that was the last step. Once I'm sure that I peeled all the posterior membranes up to the periphery and I know where the retina should stay, then I do the retinotomy.
Yeah, but in your case, the funnel was closed and retina was cut.
There was connection a bit. There was connections, I think, inferiorly.
If there was connection nasal side, there is connection nasal side. I leave the connection until the end. I never cut the retina at the beginning, otherwise I can't stabilize the retina. I don't know where the retina will lay later on.
So that's why a great point, counterpoint, where the retina, for the people who are listening to us, if you have a nearly 360 retinectomy but just hanging up there, if you cut it early, the funnel will stand up. So the PFCL, if you happen to put PFCL, is not going to tip out. But the other counter argument is that it's actually good to keep something attaching the retina so that the retina does not rotate much. So I think two great points.
Absolutely.
About Hilon as a good way to explore things, especially if you have posterior breaks and traction, and this PFCL 120% and not 100% will go under the retina. So good point. So Dr. Fayad, we have a question here. Maybe we start with you and then go to the other panelists. If you're doing a primary retinal detachment, the problem is if you do not use pure fluorocarbon liquid and it's too difficult to drain a significant amount of the fluid from the break, you need to do a posterior retinotomy. Do you do that?
No.
You don't use pure fluorocarbon liquid?
I don't do posterior retinotomies. Even if there is some subretinal fluid left underneath the retina, I don't mind. First, if it's a classical retinal detachment, I mean, I just do scleral buckle. But if I have to go inside the eye, I mean, I don't do posterior retinotomies. I mentioned that before.
Yes.
And
But if there's too much fluid, and let's say there are inferior breaks, so you really need to get a bigger fill, would you use then perfluorocarbon liquid, and you don't do retinotomy?
if there is inferior retinal break, no, I don't do retinotomies. I don't do retinotomy. Posterior retinotomies never, even in anterior. I mean, inferior and anterior retinal breaks, I just position the patient in supine position, and it will do. It will do.
Sure.
Even if there is some fluid left, of course, not much fluid, but if there is some fluid left, it will do.
Yeah, that's a great point, and I think I would definitely second this, that you can leave fluid, but the problem is with like inferior breaks and too much fluid. So the question really is from Dr. Habib here, Ahmed Habib. For people who do posterior retinotomy, and I sometimes do it, do you see PVR coming from that? If you do a posterior retinotomy in primary retinal detachment, Lucan, do you do any posterior retinotomy sometimes in primary detachment?
No, I think it is obsolete, and it is from the time of contact vitrectomy where the field of view was 30 degrees. So I don't go in the OR for retinal detachment without chandelier and without PFCO.
Okay, all right, good point. Noor, is there any posterior retinotomy in Turkey?
Maybe some surgeons may prefer, of course, but I do not do it. And I agree that the vessels are really active in the posterior pole. On the other hand, we had a panel maybe last weekend. There are some people, especially from the States, doing posterior retinotomy. And the thing is that the primary, very fresh retinal detachment is very, very different than those cases. These are really excellent PVR.
No, the question was about, yes, primary retinal detachment.
So, I mean, I don't never, but I can understand if I peel the ILM, maybe, but I usually use heavy liquids.
And Carlos, do you do posterior retinotomy in primary detachment?
No. Yesterday I was with Ahmed and we were mentioning this, and I never do it.
I sometimes do it. I don't see PVR. I actually either laser around it gently or don't laser around it because it's very near to the nerve. I try to avoid it. I try to drain from the break and leave the fluid. But sometimes, like if you have too much fluid and it's inferior break and you need to get a good tamponade, the option would be using PFCL or drainage retinotomy. Advantages and disadvantages to everything.
You are lucky, Ahmed.
Yeah, right. I think just to summarize, Dr. Fayad, you have one more video, right?
Yes, one more video.
Please go ahead. Please, we're enjoying it.
Thank you. This is another video, severe hypotony, 18 or 19 years old boy. He had lens that is luxated over into the vitreous cavity, as you can see it, with giant retinal tear with PVR. This is my preferred technique once more, bimanual approach to PVR membranes. You can see here, you have to do almost complete vitrectomy before you go and remove the luxated IOL. Even you have to put some heavy liquids to flatten the posterior pole to protect the retina. Then once the IOL is completely free, you just take it out. Iris retractors, and back again to do the job. This is HD video, it's not 3D, it's a little bit old, not too much old. And you can see here how I peel the PVR membrane from the edge of the giant retinal tear. You can see it bimanually with 2 forceps. As I mentioned, I try to spare as much retina tissue as I can. And as I mentioned, I don't cut the retina at the beginning. If there is need to cut the retina, I just cut it at the end. Here, I do everything before deciding to cut or not the retina. Here I decided to cut the retina, and it is cut now for 360 degrees. I cut the anterior flap, no diathermy in this case. And this is how it looks like. This is a couple of months later. You can see there is no PVR, there is no recurrence of PVR, just anteriorly because there was quite large posterior ILM peeling. I call this benign PVR anteriorly, and just some air inside the eye.
Dr. Fayed, thank you so much. This is so beautiful. Noor, do you want to get ready with the video as we complete the discussion, please? So, Gianpaolo, what do you feel about what type of oil you use? When the PVR, do you ever use gas in PVR? And what if no or yes? And then what oil do you usually use?
PVR to me is the equivalent of silicone oil. I do not use gas. Silicone oil, I only use the normal silicone oil. So I'll be using 1300 centistone rather than 5000. I never use heavy oil. I don't believe in heavy oil. So I don't do that.
Noor, can you please get your presentation up if you start sharing? Does anyone use heavy oil? Carlos, you mentioned you use heavy oil.
A lot.
And so what's your indications for
inferior retinotomies? Inferior retinotomies, you know.
Okay.
We believe in tamponade or not? If you believe in tamponade, we have to use heavy silicone oil. Because if you use non-heavy silicone oil, the patient is looking forward, you know, you see in the optomap pictures, you see, you know, the inferior border of the silicone oil. You know, the problem with the heavy silicone oil is it's not as chemically pure as the 5000 or 2000 non-heavy silicone oil, and more inflammation. I strongly recommend to continue with drops of steroids. You know, I speak too much.
Can I just add something to that?
Sure, of course.
So I fully agree. The patient has to be tamponaded. Now, at least what I do, if I find that the retinotomy is unfortunately posterior enough, then I don't feel I need a heavy silicone oil because the normal silicone oil would be enough. If, on the other hand, the retinotomy either has not been performed or it needs to be performed anteriorly, then I always have a buckle which will help me with the silicone oil. It's a question of preference, I imagine. There are many ways to skin a cat. As long as you have the silicone oil, whatever sort you're using, either heavy or light, tamponading, that's good enough. And if you're putting a buckle in, you will have a tamponade.
Luca, please, how long do you leave the heavy silicone oil in?
So I have a strict indication about using a heavy silicone. It is break from 4 to 8 o'clock in the lower part and not up to the equator. Everything above the equator will be dealt with lighter silicone, 1000, 5000 no matter. And I find in my hands that Oxan HD is fairly stable up to the 6th month, because in our country, the economics, sometimes patients get lost a little bit, but I try to remove it like up to 3rd month. With the Densiron 68, I have sooner emulsifications.
And Oxan HD, which company? I think Densiron is
Bausch & Lomb.
Bausch & Lomb.
Densiron is Goiter, right?
Mm-hmm.
Yeah. Okay. I used to use it in England. It was available. I would use it similar to what you do, Lucan, but I would remove it after 6 weeks. But in the US, there's no heavy silicone oil. Okay.
There's no need for a heavy oil on that.
Right. Quick question to the panel about using something for PVR or to prevent PVR? Does anyone use methotrexate or 5-FU? Anyone using anything in this in clinical practice? No.
No.
No, just clean surgery. Clean surgery.
Clean surgery. All right.
That's the issue.
Perfect surgery.
Yeah.
I think the point is that you have to do the best possible surgery in the beginning, and
Yeah.
this is something that a lot of people now forget because they're in a rush to get as many cases as possible. Somebody mentioned money before, but I think it's better not only ethically but also financially to get the patient right the first time rather than have the patient go back 2 or 3 times to the operating room with a very bad result. So it's the first time that counts. You have to have a very good vitrectomy, very clean, remove as much inflammatory agents as possible, and then that's the best you can do, really. We don't have a magic wand.
Absolutely.
Do you leave triamcinolone or use Ozurdex? Again, another question about steroid, or give systemic steroids with PVR. I tend to leave triamcinolone behind. Sometimes I shoot in an Ozurdex if I have an Ozurdex sample. But do you do any of these? Carlos, you do?
PVR, you have 2 main reasons for low vision. One is macular edema, the other is macular atrophy.
Yeah.
And in cases, even with silicone oil, I put Ozurdex inside the eye just for the macular edema. Then I use Ozurdex sometimes, and sometimes triamcinolone.
Right. There was actually a randomized study, but they did not show benefit. But it seems, I mean, we think that it's not gonna at least will help the macular edema. So that's the answer. So Noor, please go ahead.
Can you see the screen now?
Mm-hmm.
Yes.
So very beautiful videos. Really, I enjoyed your cases a lot. So my first case is, they're all fastly edited videos. Sorry, usually the maneuvers are much more gentle. This is a case like a 12 years old male with a chronic detachment presented with light perception. The only history is a premature birth, and so I planned to do a buccal, phaco, IOL, and vitrectomy. So, I'm sorry. So the case starts after I put the buccal, I did the phaco, I put the IOL, and then 3Ps. And then, of course, not such a maybe like fixed pose like yours in the posterior part. The thing is with these cases, again, is the posterior hyaloid is really very adherent, attached. And triamcinolone in my PVR cases, I sometimes inject. I shouldn't do it. Okay, sorry. I inject. I started the triamcinolone injection. See the posterior hyaloid, of course, and then with aspiration we can even leave it, remove it until maybe between the arcades, maybe it's some to the mid periphery, and then starting with the heavy liquid, under heavy liquid, as all of you mentioned very beautifully, starting from the posterior to the anterior, doing a very, very complete vitrectomy. Start trying to remove all the vitreous, but as you know, this is a pediatric case also. The vitreous is really attached, and I almost always do the ILM peeling, although it's not a posterior PVR, mostly anterior, but I do the first pinch under the liquids if possible, and then with the heavy liquid like a turpent, because especially in the pediatric eyes, the ILM is really adherent, really very tight adherent. So we go and peel the membrane as much as I can, at least in the macula, but between I try to get outside of the arcades, but usually or sometimes it is very difficult, especially in young eyes like this. So by manual thing, I go with the, as you can see, there is no fixed membrane so much formed. They are much easier to peel, but this is actually more difficult. You should shave, but you cannot lift it up. And then sometimes by manually, I try to lift as I showed here. I'm going to the periphery, but as I continue with the surgery, it may not seem like that, but the intraretinal traction is apparent, especially in the inferior side, in the nasal side. And I do a complete shaving all around 360 degrees. But at this point, As you can see, I try with the indentation. There's so much indentation needed. I usually check under heavy liquid if the retina will attach or not, and then I decide here doing a 360 retinectomy. So, sorry, and I usually, I don't know if you use, I can ask the panel, a tail diamond dusted forceps useful to lift those, they can tear the retina, of course, we have to be very careful about using them, its angle and everything, not in the arcades, not in the posterior retina, but in the periphery. It is really helpful sometimes to lift those very little vitreous crises like membranes, we are not able to peel. So I do in this case, because it's a young eye, quite posterior maybe, but I can see the vessels are really very active. You can see how thick or constricted the retina is. So I had to do a 360 retinectomy in this case. So, and also I did a endodiatemy because all around, because in this case, because young eyes really bleed much more than the adult eyes. So, and under heavy liquid, I move forward, and sometimes I'm already will cut the areas that I will going to cut, and then under liquid I just inject and sometimes cut under the heavy liquid and raise the infusion pressure a bit just before I cut. And if I wouldn't like any bleeding at all if possible. And as you can see here, the posterior retinectomy, we must remove all the retina here in this case, and according to the posterior process is very periphery. And in this case, usually you do a 360 retinectomy. Sometimes it is in the young eyes, there is a really strong proliferation, and we may think about removing the IOL that we put in the first place. But here I remove the buckle now because it is 360 now. In this cases, I can do dry with air first in the periphery and wait sometimes, inject some, and then at the posterior part remove the fluid. I inject some fluid under air and to remove the decline particles because they attach when you move. When we do with the small gauges, they attach on top of the retina some places, not all around. All the bubble comes like it is in 20 gauge. So we have to check it, more fluids, and then this is the air silicone exchange. I suture all my wounds, and the retina was really good. At 6 months, I removed the silicone oil, and the thing is, I did a very large posterior capsulectomy in this case. But here, as you can see, that's another thing to maybe discuss. Just before silicone oil removal, as you can see, these eyes really proliferate or tend to proliferate. So the capsule is looking as if I did nothing to it. So there is this can also lead to sometimes anterior traction in some eyes. So in these young eyes, when we put an IOL, so we sometimes may need to do a large YAG laser also during the follow-up. So this is my first case. Can I move on?
Yes, please, please.
Yes.
Okay. So this is another case, actually, 13 years old male. This is an educative case also for me. As I always tell, I always peel the ILM in posterior pole or as much as I can. But sometimes we speak or discuss with our colleagues and saying that ILM peeling, okay, but it may cause sometimes foveal atrophy or we may damage the macula or something like that. So this is a 28.
Sorry to interrupt. Can you enlarge your go full picture?
Sorry.
Thank you so much.
So it is a very highly myopic eye. This is a history of ROP treatment. He had vitrectomy, cryo, laser PC, and so it presented with as a referred patient with a chronic detachment. At least for 3 months of history, he doesn't know, and so light perception vision. And I start with a vitrectomy, not a buckle in this case, because I think it can go to the 360 retinectomy again. I remove the lens because when I see here inside, I remove the lens, and I want to remove all the severe processes to prevent hypotony, postoperative hypotony, and it was already hypotonous just before the surgery. As you can see, I dye with the dual blue dye, and I do the peeling. It is easy to peel these membranes because they are formed, and not. It is with the. I usually prefer this long-armed Jobs forceps of Encoding. It's very powerful, and I think that okay, I did a very good job. I peeled all the membranes. Why not peel the ILM in this case, for example, for the first time? And this is why I bring that. We will see the results in a minute. So I use a tail of forceps in the mid periphery and the periphery because again it is the membranes kind of also vitreous, very adherent stick to the retina, and I peel just before any retinectomy. I try to remove, elevate, and then remove all the vitreous. And as you can see, the large cryo spots, and you cannot delineate the effective retina, healthy retina, and so it is a bit difficult to complete the retinectomy peripherally because there's not much retina alive there. So I go now 180 degrees of inferior retinectomy. I clean all I can see again in the periphery, the severe processes. I do the laser if I in the periphery the things that just I cannot cut left. I do the laser, and this is again heavy liquids air exchange, followed by a standard silicone oil exchange, peripheric iridectomy at the 6 o'clock place. So it was beautiful. The vision went to maybe 10%, but at the first month. So this is the second surgery, and the standard silicone oil. But I believe I agree with Gianpaolo that usually, even with inferior retinectomy, because it was quite posterior, not so periphery, the normal silicone oil works. This is, in this case, the thing that I want to emphasize is the not ILM peeling, because the posterior, this is a difficult case. I mean, very big eye, ROP, and vessels really active, as you can see. So this is the 1 month membranes formed, as you can see in the macula. So it is easily peeled. You can peel it very beautifully again. But now, of course, I want to peel the ILM now. I should have done. I prefer to do it in the first operation. So under liquid, it is really adherent, unusual in the young eyes. So I try to move and remove as much as I can, at least at the arcades, and trying to pass the arcades. But sometimes it's really difficult because it is circumferential, so it is not coming into complete in one piece. So here is the image. So I go again with the Tano. Whenever the second tip, maybe I do, whenever I do a retinectomy, because you can see all the retinectomy areas are curved. So with the Tano, I cannot remember, although I don't remove the ILM, with the Tano forceps, of course, you disrupt the ILM here. So it is giving you a more cleaner surface, at least just before cutting again. So as you can see, the superior retina is looking good without so much PVR. The problem is in the posterior part and the inferior. We always check the inferior of the retina if there is any membrane. There are some pigment clumps, as you can see. And I go forward to enlarge the retinectomy areas to the sides. In this case, and cutting just the curved areas because they will again just retract in time. So, and trying to again clean the periphery as much as I can, doing the iridectomy in the 12 o'clock now, and giving this time a heavy oil. So this is, I think, the indication, because not in the first surgery, and we should remember that the superior retina gives the inferior visual field. So inferior visual and central visual field, of course, is much important than the superior visual field. So in the first operation, if there is not indication, of course, we should try to protect our inferior visual field. And normal oil usually this is very rare cases that I use a silicone oil, heavy oil. So, and it's this is the third, but I think maybe if I don't have time, I may stop here.
Right. Well, thank you so much. This is a great, Noor. Gianpaolo, do you have any questions?
Yeah,
Akar?
I just had a question for the panel and for Noor in particular. Did I get it right? Did you say that you went from PFCL to air and then silicone oil, or in one of your cases, or did I miss?
Yeah, I think that's.
Yes. Yes, actually, doing it the standard 20 gauge, I always do a heavy liquid silicone oil exchange. But with the smaller gauge, sometimes we have a chandelier, but if you don't, we give it the injection, the silicone oil. So we need another, we cannot connect with the infusion, not connect to the infusion fluid. So with air, actually, it is doable because I first dry the peripheric retina, if there is a peripheric tear or the retinectomy in this case, there are large areas, and then coming to the central, getting all the fluids and waiting for a while like we do in the macular hole, and some fluid comes to the posterior again. So drying again those fluid, and then with the dry retina, so there is no slippage, as we can suggest that there can be a slippage in a giant tear, but it is doable like this too. I didn't see any slippage.
I generally like to go directly from PFCL to silicone oil. I can inject, if I have obviously a chandelier, I can inject through one of the ports. If not, I can connect through the fusion line, and I still, with the small gauge, get good results. What about the rest of the panel? Any comments on this?
It's a great question. So direct PFCL silicone oil exchange or indirect through air? Dr. Fayyad?
It depends. Mainly, I do direct exchange, but sometimes I go into air, then I go. If there is a chance of slippage after long hours, I just go direct exchange. I have better visualization, and I feel more comfortable. I feel more comfortable with direct exchange.
But when do you go to air? Because when you worry about the visual.
I go to air once I have limited retinotomy, let's say 80 degrees up to 90 degrees. If I have larger retinotomy, then I would go to direct exchange because there is more chance of slippage.
I always go to air exchange exactly because I need to see if the retina will go to slippage, because I don't believe we can anticipate or predict if a retina will contract or not. When we do a direct silicone PFCL exchange, we sort of get rid of the slippage, but it happens later. So the first thing to do is to go to air to see if the retina will stay attached.
That's the great thing I mentioned in the beginning. You know, nothing white, nothing black. You know, I never do directly. I hate it. I'm so sorry. I hate it. And you know, I want to see if the retina goes down, and I inject the carbon liquid, and I go up. You know, no. I want to comment with you. I want to comment. You know, in the first case, for example, you at the end you said, okay, you did a marvelous surgery, and then you say, okay, the buccal, I'm going to cut the retina. I remove the buccal. I will never remove the buccal. I will leave there, you know, because at the end, as I mentioned before, when you it's your option and my option are different, okay? But you know, I understand your concept. Less things around the eye, but I would leave it or tighten more. No, don't leave it.
But Carlos, why? Because I remove all the retina.
Let me tell you, because at the end,
without. I mean, you will change, of course, the eye contour, but for what? To make the eye small for the temple?
Yes. Let me try to tell you. At the end, when you cut the retina, you try to cut it as anterior as possible, right?
Yes.
Then the anterior goes down, and the circumference is larger. Then, you know, if it's larger, you have, you know, the retina is stretched, not relaxed. Then, you know, it's you know, different thinking, okay? But you know, I would never remove it. I will leave it there. You can remove it in a second procedure if you want, but you know, I would never remove it.
I think this is
And
great.
I understand.
That's why we're
I
here.
understand. I understand your point, Noor. I understand your point. Absolutely.
I think that's why we're here, because if, like,
Yeah, to
as
discuss
Carlos
it.
was saying, if it was
What
black
about
and white,
the rest of the panel? I'm also want to learn others' opinions.
yes, and that's why we're all here. Is no black and white.
Yeah.
For the
No
people
black and white.
hearing us, the direct PFCL silicone oil exchange, the full stop. There is no slippage. Full stop. You cannot have slippage. They are both hydrophobic. They kick out the BSS, and there's no slippage. The problem is the pressure can go high, and that's the main problem. You can even rupture the eye, and that's why
Yes.
this technique is really not very widely practiced, and some people shy away from it.
Not very controlled. Not very
Not very
controlled.
controlled, especially
Very
if
controlled.
you're doing a passive removal of the peripheral
Yes.
coverage. The air is very nice, it's controlled, but then the slippage. So, take this for now, and I think we will need a session on on PFCL silicon oil exchange. Jim, how would you?
Hamid, can I just say something? I really don't see the danger of the direct exchange. I mean, I like what Lucan said about it's you're checking if you've done everything right, if you put the air in, because you are checking if you removed all the traction and so forth, which is great. But as far as the direct exchange and being afraid of a dangerous procedure, I really don't see that. I mean, if you got a good view and you see where the PFCL is, what's the issue? You just get it out very easily.
I think, as they say, there are lots of kinks and corks that needs to be sorted. So, and the problem is it's not very widely taught in fellowship programs as well. Like North America, for example, is not widely taught. So there are issues. I think if you're used to it, it's a fine, but it's not like as easy as the indirect exchange.
Yeah, well, but it's something like a giant retinal tear.
I agree.
But anyway, the buckle is very useful. Because again, it's lovely to talk about these things, because I think we're all right and then we're all wrong. Because every case is so special and particular. It's only experience which will tell you what will work when, and then you may be wrong again. In some cases, actually, you are wrong sometimes. But the buckle gives you the added, at least to me, it allows me to tamponade with silicone oil. It's not heavy silicone oil, because it gives me a different shape of the eye. If I've done an interior retinotomy or retinectomy, as you prefer. So whichever, I think that the fact that I have a supporting buckle from the outside, I think is always a relief.
Right. I think for the sake of time, we'll have to move up from the direct indirect exchange, because it will take a long time, and I think it needs a session on its own. So, Lucan, would you be kind to please upload your presentation? Maybe that. Yeah.
Is it already there?
Yes, sir. It's there.
Okay. So, can I start it?
Please go ahead.
So this is my case. It is a post-traumatic PVR case, a trauma with knife. The eye is aphakic. And this is what I found in the posterior paw. I tried to drain a little bit of the subretinal fluid to see if the retina will flatten and the funnel will open, but sadly it not. Then I will use a PFCL to unfold the funnel and to see the stability of the retina and where are my if I have any breaks, or where are the membranes which are responsible for that condition. Under PFCL, I clean the anterior vitreous in far periphery to see if relieving the peripheral vitreous will relieve the retina to the posterior paw. Obviously, the macula is twisted down there. Now I will remove the PFCL with 2 cc syringe, and I will reuse it later, of course. Then I use membrane blue duo to stain the retina and to see where are the membranes. Again, the PFCL, which actually beautifully pushes up the remnant dye through the folds and reveal the not so pretty picture of the PVR there. So remember, this is the first surgery, so this is untouched eye in the posterior pole. This is beautifully stained remnant posterior hyaloid along with the ILM, and you see the twist around the optic nerve. All the macula is twisted to 6 o'clock. Now I will try to peel the ELM, and I do it under PFCL as already pointed. It is more controlled and safe for the retina because we don't want to have any holes in posterior pole. Otherwise, if we create a iatrogenic break, we will create a path for the PFCL to go subretinal. Now you see how when we remove the membranes, the macula flattens a little bit, but still all the retina is twisted. I use always chandelier because in these cases we anticipate by manual work.
And where do you place it, Lucan? Where do you place the chandelier?
That depends actually. In the past, I used to place the chandelier nasally or temporally. Now I do it in 12 o'clock because of the ingenuity. You need to see and to guide the light to have the better image. Here, the chandelier is on 12 o'clock.
Right. Nice.
And these are additional membranes. This is actually remnants of IOM because the hyoid rarely stains with trypan blue. Now I will remove a little bit of the PFCL in order to start my peripheral retinotomy. I have really low threshold for radical behavior in such cases. I don't do any diathermy because the bleeding is something that stop after a while. We can increase the infusion pressure or wait a little bit. Now I will do almost 260 degrees retinotomy, but will leave the upper part attached in order to not have a twisting funnel. I will clean the subretinal membranes and PVR if I see them. I always like to use two forceps, and I like the stretching maneuver between the forceps. That way I can see where the retina is engaged with the PVR membrane, and after that I can peel that membrane. Now you see how the retina unfolds. I really like the crocodile forceps because there is a lot of gripping force there. I switched the instruments when I needed to do that. This is, as I call it, fresh PVR, but still is really sticky because this is probably a trauma case. Now I will remove additional amount of the PFCL again in order to reach behind the retina to remove subretinal strains because they will later contract the retina under the silicone if we don't remove them. Here I will switch my instruments because the Eckert forceps simply cannot hold this membrane, and the crocodile is the perfect one for the job. Now again, I will put PFCL, and with 2 forceps, I will rotate the retina on his presumed place. Because of twisting, we have traumatic translocation of the macula. Now I will do a radial cuts in order to alleviate the difference of the size. You need to think like a tailor here. You need to tailor the remnant retina to the sclera. So that is why I don't use buckles. I just cut and tailor the retina to the surface that it needs to attach. This is the retina under PFCL. This is already lasered. This is first day post-operative. The red free is not so disturbing, but the fundus autofluorescence is a little bit disturbing. And this is 6 months later, the silicone oil removal of the same patient. The function was around 0.2, but with double vision, which was already mentioned because of the macular translocation. This is my case.
Lucan, thank you so much. Very beautiful.
Yes, excellent.
So, Lucan, can I ask you sometimes, and also for the panel, and sometimes when you peel the membranes are not too mature, and they are immature. Gianpaolo, what what have you seen that before? Like a case of PVR not operated or operated early, not too long standing, and the membranes are not mature enough for peeling.
Well, that's what I was telling Lucan when he was carrying out that beautiful surgery, and he said it's fresh, and I didn't want to interrupt, but I wanted to tell him fresh is more difficult because obviously once we have the membranes which have formed and developed and been there, it's much easier to peel them. When they are fresh, it's very difficult to grasp them. Even if sometimes you can use a diamond dusted forceps, but even then, it's very difficult to grasp them. On the other hand, you have to consider that the sooner that you approach the eye and the sooner you put the retina back where it belongs, the better the outcome. So it's a very difficult balance to strike.
The case was a month and a half old, so I presumed it should be fresh, but it was not so difficult to remove the membranes, actually.
And because some of the membranes were already mature, but sometimes you get membranes which are very immature, like Ahmed was saying, and it get a bit more challenging. But this is obviously a difficult case.
Yeah. Dr. Fayyad, do you encounter this situation sometimes? And the other question, would you sometimes delay PVR patients maybe for a few weeks for the membranes to mature? Is this, sensible?
No, I don't do that. I don't do that. I agree that it's much easier to peel mature membranes. But, once you have a patient with retinal detachment, of course, I would schedule him for surgery. It's not emergency. I don't consider it's an emergency case, but I would schedule the patient for surgery. Absolutely. As soon as I have time, I'll do him. But I don't, postpone the patient waiting for PVR membranes to mature. Absolutely.
Carlos?
For me, this amazing case, wonderful. What's the main problem of these cases? Hypotony. This is the main problem. These cases, the main problem. You remove the membranes, impressive. You rotate the retina, impressive. But the big problem in these cases, you put silicone oil and they stay in 4 millimeters of mercury, and then you cannot remove the silicone oil, and then you have more membranes because there is no fluid to clean all of this debris and all of this stuff. And for me, this is the main problem of this case. But your case was amazingly good. Amazingly good.
And,
Yeah, no, Lucan, this is a fantastic case.
and yes, and this is why, I'm sorry to interrupt, but this is why we haven't made it point, but when I was talking about indentation, when you want to see the ciliary body as well, because if you want to get to the ciliary body and try to debride as much the ciliary body as possible, because that is the only way you're going to try and prevent hypotony. And as Carlos rightly said, it's no use getting the retina back where it belongs if you're going to lose the eye because it becomes tricycle because of hypotony. So something we have not mentioned today, because we're focusing on the retina and removing the membranes, and it's all very well. But remember, the same membranes and the same attraction that you find on the retina is on the ciliary body. It detaches the ciliary body, and therefore you get hypotony. That is why so much effort must be put into ciliary body debulking. And the way you do that is obviously with a clear view in an aphakic or pseudophakic eye, where you can indent and get to the ciliary body and debride it.
One thing to mention.
Usually, unfortunately, it doesn't work. Question me about the outcome. So I think that's all.
If you do it too late, it doesn't work. No, if you do, but sometimes it does. I mean,
one thing I want to mention, that is why I never use cryo, because cryo is one of the reasons also for a ciliary body disruption. What do you think about that?
I never use cryo, and I see a lot of these. I don't use cryo many years ago, but I see many of these eyes, and I operate many of these eyes, and at the end, hypotony is my problem, and I don't have any solution because you remove the silicone oil in 6 months. I have these cases for 10 years, and you cannot remove the silicone oil, because if you remove the silicone oil, pressure goes down and you go to phthisis. Then the cornea, pancreatopathy. The problem in these patients is not the membranes, is hypotony, and we don't have any solution for that.
Actually, last year in Retina, Dr. Zurman presented some substance from goiter, which is under development exactly for continuous tamponade in hypotonic eyes. Something like silicone, but different than the silicone, and not that the Vesper body, which was silicone back. It is a silicone oil, but for sustained maintenance of the pressure of the eye. So you put it there and leave it there.
I leave the silicone oil. The problem is the pancreatopathy, is the problem.
And emulsification, etc.
Yeah.
Question about immature membrane. Back to the original question. Do you find that difficult? Do you have any tips for removing it? Would you delay surgery for that?
For me?
Yes. Yeah.
No, I wouldn't postpone the surgery, but I have maybe the third case with the immature membranes. I think Tano or the silicone tipped brush forceps can stick to the membrane or the very tightest layer of the vitreous, and then not to the retina, but you can just gently elevate, because you feel the sticking of the Tano forceps or the silicone tip to the membrane. Then you can elevate a bit, and then you can cut with the cutter. And sometimes with the peel with the membrane, when you elevate it, we can peel it. Maybe my third video, you will be interested. If we have time, I can show.
We'll get back to you once it was time. Jim Paolo, would you like to upload your presentation, please?
Yes. Well, this actually, as a moderator, I promised myself I did not present anything, but this came. I think there are a few good points to this presentation. Once I'd seen yours, because it sort of underscores what many of you have said. So this is a patient that essentially has came after primary surgery elsewhere, and she had a very hazy cornea because she had corneal dystrophy. So the first thing was being able to see what I was doing. This is a very old video, but it has some value also for a few more things I would say. So you see that this is very opaque this cornea. So we obviously have to see properly, and this is what Carlos was saying about about being able to visualize what you're doing. So we could not use a baron. This is instrument, I don't know how many of you are familiar with. It's a very old instrument, but it did the job. So you use a keratoprosthesis, and then you see this is a mature PVR. You see that we got pigment to guide us. Obviously, we do the healing under perfluorocarbon, and this is an illuminated cannula before the chandeliers actually came on market, and it was placed in simply because it was foreseeable that we would be doing bimanual surgery. So here you see that again you have to be careful not to induce any tears, and the work is done obviously, as I said before, with PFCL. Now is the type of bimanual. So you hold the membrane with with a forcet and with a pick. Actually, this is not a pick. This is an MDR blade, which helps us dissect the membrane. And now another point is staining, which is done under air, at least in my experience, because it simply gives better staining, and you continue to peel the ILM as far as you can under PFCL, and then in the end you get relatively flat retina without performing any peripheral retinotomy, and all you have to do is essentially go and laser the hairs which were present in the first place. This is not a retinotomy, it's just the hairs that were present in the first place. So that's it. And essentially what it tells us is that things have not changed very much, because this video is 15 years old. So things have not changed very much in these last few years. We're still doing the same things. We haven't found anything better to deal with the problem. So it has a historical value, if you wish.
That is very nice.
The main thing is that you need to be able to see what you're doing, whatever it takes. So in this case, you get a characteristic system.
Noor, do you want to get your video up? Yeah, I know. Yeah, go ahead, please.
I mean, if we have time.
Yeah, no, I think go ahead. Right. So until Noor gets her video up, just a few points really of discussion. So again, the point for hypotony, the main problem, as Carlos is saying, and Gianpaolo, is the PVR membranes. So always try to remove them. If the ciliary body is working, it may work, but sometimes, unfortunately, many cases it's all shrunk really, and you can see it. You can see the ciliary process. Another reason is the retinectomy, and maybe a school of thought is to delay a big retinectomy to avoid the hypotony. So just to mention this, Noor, yes,
maybe about there may be also ciliary body detachment, and buckle in the anterior placed buckle can help that.
Yeah, that's a good point, really, because it will push it back if it's still functioning.
Yes, but it can create ischemia of the anterior segment also.
That's again, and that's why we're here. That's why this webinar is here.
But let me ask you one thing, because we're commenting things that are written in the books. But you do UVM in these cases. I almost never find choroidal ciliary body detachments. I never find them, and I try to find them, and I don't find them. I don't know what's going on with the ciliary body. Ischemia. I don't know.
It's really inflammation.
Inflammation.
It's chronic cyclitis, membranes.
Yeah. Chronic cyclitis. I don't know, but we don't have any treatment for that, because chronic cyclitis steroids, for example, could work, but they don't work. I put all my patients are on the steroids. They don't work, and they stay in 3, 4, and I cannot remove the silicone oil. And that's and the retina looks, magnificent, but at the end, it's a big problem.
I do lots of uveitis work, and even if uveitis, once you go into hypotony, it's really the end of the game. It's just the end of the game, really. Mm-hmm. Even if you peel membranes, it just does not work. Your luck would be if it's a trauma, ciliary body detachment and you can see it, yes, that's it goes back. But otherwise, I mean, in my view, it doesn't work. Noor, please go ahead.
Maybe in the future there will be stem cell. I was reading about that in some places, you know. Maybe can be a solution. I mean, stem cell implantation, something like that. And there's also a Chinese implants. I've seen it, but I didn't try it in the eyes. You know, it's like a bubble, plastic, something like that. You just inject it into the eye and fill it with the silicone. I think it is a nice idea to be improved with the finer material. It doesn't touch the retina, but just for hypertonic eyes. So this is the last video. Not so
and you can make your video big, Noor?
Yes.
Thank you.
So this is a young guy, highly myopic. It's a very fast video again. Minus 24 dioptry, only seeing eye and light perception. So just starting from the posterior to the periphery. It's a fast video. I'm sorry for that. But the macula is atrophic. I cannot see even this side if there is a tear or something like it, the temporal macula. So as you can see, I just want to lift the posterior hyaloid, find the plane. You can do something after triamcinolone again until some point into the mid-periphery. But I don't want to go forward before I'm sure that I lift every membrane in the posterior pole before injecting heavy liquid. So the capsule is only, it is a minus 24. She did a clear lens extraction, I think, and leaving the capsule. And I removed that too, again, to clean all the processes, ciliary processes, do a complete vitrectomy. So as I mentioned here, with the Taylor forceps and then with the forceps after lifting, you just can feel the places of the membrane because it is sticking into your, it's a really fast, I'm sorry, but in the, you can feel it when you do it with a gentle maneuver, of course, because you can tear the retina and you should obey the movements, the contour of the eye inside the eye while doing that. And then you can, as I can see, I found the membranes and it's an old video. I didn't want to peel the ILM in this case because the macula looked very difficult to do that. Very thin retina as you go to the periphery and shaving all the vitreous again by manual shaving, meticulous shaving, and you can see the ciliary processes. I always clean, no remnants of capsule and all the area. If you do a clean job, and of course the ciliary processes are not atrophic yet, so you don't realize it. Even in a retinectomy eye, actually, this is not my usual. But trauma is something different. Traumatic eyes, already there is some disruption in the ciliary processes. So I go forward and to the periphery, like all the areas. And although I didn't plan to do a buckle, for example, this is a fold. It's a bit that I couldn't open in the first place, and the retina is the superior nasal is a bit tight, still tight. But after you do the cleaning again from the periphery, and with the forceps now, you can just unfold this fold somehow. Sometimes you cannot lift it. You can lift the membrane whole, but you can just make a pinch of the membrane so the retina relaxes. So as I can see that the retina looks very nice, but there's a hole in the 6 o'clock and also in the 12. I put a buckle. So now I put the buckle and I see the indentation nicely. The holes are covered, and do the silicone and heavy liquid, do the laser 360 now in these cases, even the posterior part of the buckle a bit, and then iridectomy and direct heavy liquid to silicone exchange. So I think this is it. And a fake guy, of course, you do inject some fluid into the anterior chamber and some myostat agents, so the pupil constricts, and we shouldn't leave the anterior chamber so hypotonic compared to the posterior pole. We should be careful about the tonus of the eye, because not to silicone oil come forward. Thank you.
Noor, thank you so much. This is very nice. So we have a question here about PFO use. Whether it's from Dr. Saad, we have from Saudi Arabia about using PFO for PVR tamponade and maybe use it with methotrexate for a few weeks. Does anyone of the panel endorse this? I use PFO for giant retinal breaks, but I don't use it for PVR. My feeling is we need something longer acting in PVR. It's a cycle. And PFO leaving it short term is not enough. But does anyone of the panel use this?
No.
No.
I fully agree with you. The PVR takes 4 to 8 weeks to develop again. If you leave it for 2-3 weeks, it's nothing. I used fluorocarboleucate during 2 weeks when I was performing limited macro translocation 20 years ago to move the retina upward. And at day 10, 12, some white cells were appearing in the aqueous phase of the vitreous cavity. Then I don't know. Steve Charles is the guy who described this, and but I don't use it.
Actually, mainly described in New Zealand. I can't remember the name of the group leading it, like a short-term tamponade in giant retinal break. But
really?
You're right. Steve Charles uses this in PVR, but I feel the same view. It's a cycle. Right. That's good. I have a case here. I would like to ask you what you would do. So this is a patient who had multiple retinal surgery, PVR, and you can see there's an encirclement there. And this actually view is under under silicone oil. Sorry, under silicone oil. And the problem is there's a localized PVR here, central to the buccal, with a break next to it, and also the macula is off. So you need to intervene. So if it's a peripheral PVR under oil, you may wait until the cycle ends, but we need to intervene because it's the macula off. So question here to, if we have quick answers before I show you what I did, Jim Paolo, what would you do in this case? Under oil, PVR, macula involved.
Peel.
Peel, okay. Would you just peel and put oil back? Or peel under oil?
I would, yes. I don't have a lot of experience peeling with oil in the eye. So I would take the oil out and peel and put it back in. Yeah.
Okay. Would you do a retinectomy? Would you do another buccal? No.
No. If the peel is sufficient, why would I do a retinectomy? No.
Right. And Dr. Faisal, would you do anything different?
I would peel under silicone. Maybe I will exchange the silicone afterwards. I don't do revision of scleral buccal at all. I think the question, there is a tractional retinal break due to the PVR, the occurrence of PVR.
Yes.
I think you can put back the silicone oil, or you can just use gas, because it's limited. It's limited.
Yes, that's correct. And Lucan, will you do anything different?
For me, it's a completely new surgery. I will remove the silicone, then I will see how and where is the extension of this PVR, how many holes I have. I will put PFCL to push up the subretinal fluid and to see how many holes we will.
There was one break with the PVR. The PVR really, with some membranes to peel, some not. Will you do a retinectomy or?
Still, when you remove these membranes, you can create additional holes, and you see how the retina will respond to PFCL. If it doesn't flat, I will do a retinectomy and to do laser, then again silicone. This is lower. This is lower break or upper?
Yeah,
break?
it's inferior break. Inferior temporal break.
How can gas will help here? I don't know.
I mean, gas is a better tamponade than oil, even for inferior breaks. In addition to the buccal, I think the issue is that oil stays longer, but even for inferior breaks, I mean, if you compare tamponades, gas is better.
There is one thing. Sorry to interrupt, but here there is a buccal. All the tamponades, no matter gas or silicone, they try to take sphere shape. You have here buccal and the eye is not sphere, so you have pockets with suboptimal tamponade.
Yes, but actually, gas. David Wong looked at that, and gas is better than oil. I think is the problem, as I'm sure you, and I agree with you, is the duration of the tamponade. But Carlos, what would you do for this case?
Look at this. These membranes in the mid periphery are very difficult to remove.
Yeah.
You need bimanual surgery here. You have to forceps to forceps or forceps to scissors. I don't see too much indentation here. Perhaps I would go to the inferior quadrants to tighten a little bit or put posterior to this. But at the end, if I do retinectomy, I would the same. But at the end, silicone oil. Because at the end, think about this patient. Stay for 1 month, 2 months, 3 months with this. My retina is attached, not attached, reoperation again. Then they come crazy. They stay for months, and then you say, okay, I put gas because David Wong, my dear friend David Wong, said that it's a better tamponade. The patient say, okay, but I lost my life, I lost my work, and I'm not working for months. Then I would use silicone oil. And heavy silicone oil.
I think one of the advantage of oil, really, what you're saying is it buys you time, you and the patient.
Yeah.
It sometimes becomes a social embarrassment.
Absolutely.
So I totally agree. And Noor, would you do anything different?
I think I go inside, peel, dye, peel, and then maybe a retinectomy can be needed.
Okay.
Heavy oil can be an option in this case because the macula is clean, the upper part is clean, everything is clean. So heavy oil can be an option for this case.
So I that's what I did. I re-peeled. I could not. The problem, as Carlos is saying, is difficult to release all traction, and I had the option of doing a retinectomy or putting. So here, I'm sorry. Actually, I showed you while it was not shrinking much. Now this is second visit. It shrank and it came out. So I put a radial buccal. I peeled and I put a radial buccal, and I left the oil. So oil out, peeled. I just don't feel comfortable removing everything under oil. And then I put oil back again, and I just tightened the buccal a little bit to accommodate the radial buccal. And here is at the end of the surgery, and I lasered around the break again. So, and then here how it looks like with the eye still silicone filled.
Now it's a real buccal.
Yeah, yes.
No. I'm not saying the sponge. I'm not saying the sponge. I say the buccal. The buckling effect now is
I
fine.
came out and I took the buccal out, and he had macular edema, and I placed an Ozurdex. This is another case where patient, he's a child, he's 14 years, several operations, and then I did not put a primary buccal really. Which goes with is if you're not doing a retinectomy, at least you put a primary buccal. So here under oil, and I encircled him, and then everything settled down very nicely. And I came and I removed his cataract, and I took out his silicone oil. At the time of cataract surgery from the antechamber, and then there were membranes formed under oil. So I peeled that off. And then placed an IOL, and he did so well. So I think a buccal really in PVR is a very good option. And then I have another case which contradicts this a bit.
That's great. That's great.
This is another case, but this patient, and this is a situation really with sickle cell, patient has sickle cell anemia, and that's here the situation. She's also diabetic and had PDR treatment several years back somewhere else, and then went on to develop a tear, which you can see here infranasally with some traction, and then she came with PVR detachment and subretinal bands. So I was trying to avoid a buccal, and I thought, okay, I'll get in the eye and see how things are, because in sickle cell you try to avoid as much as you can encirclement. And where I work now, there are lots of there's a big sickle cell population. So here the case here, this is how it looks like, and this is the tear there, and this is the PVR, which is mainly the main problem is in the macula. And what I find, and I think you've all showed that very nicely, but for the people hearing us now, with PVR membrane, just peel slowly, because we need to give the retina some time to just like recover the peel. So just peel it slowly and hold very near to the base of the membranes and peel slowly. And peeling under PFCL definitely helps. But here, I thought it was flowing well. So that's here, looking slightly better. And now perfluorocarbon liquid to support the posterior pole, and more peel of remaining ERM and ILM under perfluorocarbon liquid and under stain. And things again getting better. And then here, completing the vitrectomy with the retina more supported. And she had a weak area posteriorly where there was thinning. There was no break. And there was some remaining traction posteriorly, which I tried with forceps to stretch it, but I really couldn't. It just remained some traction. But in my mind, I thought this is away from the break. So I decided to just leave it. And I thought, okay, I dealt with the posterior PVR, I dealt with the break, and I just, here the area at 6 o'clock. And then here, this is perfluorocarbon liquid air exchange. So that's going through air. And then washing the PFCL with some water, and then PFCL exchange. And then I place gas in the eye. And I usually put oil, but in this situation, sorry, I'll get this picture straight in. In this situation, I thought, maybe I can do, maybe she would do well with gas. And trying to find a picture. And she actually did so well with gas. I'll find a picture now. I'm sorry, it went somewhere. But my question is, would you consider using gas in some cases with PVR? I mean, there's the PVR study showed actually that gas more or less equivalent to oil, but the trend is we all use oil, and that's what I do. But were there cases would you use gas or no? That's my question to the panel.
You know, the PVR study is so old. I mean, I don't think that is valid anymore. The PVR study.
So yeah.
The Silicone study had one problem, and you know it. You know, some centers had very good results, other centers have very poor results, different kind of results, and you know the results at the end were difficult too. Let me tell you one maneuver that can help you in a case like this where you are not using perfluorocarbon liquid. When you were pulling this posterior highlight up and all of the retina is coming to you. The trick is you have a chandelier to grab 2 forceps, and instead to pull the retina to you, is to share, you know, trying to make horizontal maneuvers to share, to break, you know, the traction of the posterior highlight instead of pull the posterior highlight from the retina, and then the retina is not going to you. You're going to share this posterior highlight.
And would you do that with posterior? Because I think you know the posterior retina is thick, so it doesn't.
I know. But you know,
I do that with posterior as well.
But in the periphery for sure. But you know, here posterior, I try to.
Okay. That's a great tip.
Answer to your question about the gas.
Yeah.
Actually, when we do a buccal width, gas is a nice option. Because as Faisal already mentioned, it's an old study, but gas is really a nice template. When we peel the membranes, the ILM, and all thing, and when we put the buccal, I feel more comfortable. And if the eye is not faking, of course. So I think sometimes we use it also in the PVR cases.
Yeah, in this case, 3 was a sickle cell, so I was keen to avoid buccal, but then I thought I mean, the gases would support this posterior breaks well as well. And I believe gas is a better tamponade. It's only the duration and the social embarrassment and the PVR cycle. But yeah, I'll try to get the
Absolutely.
picture.
Which gas you use, Ahmed?
I use C3F8.
Which gas you use?
I'll get you the picture as we speak.
Which gas you used in this case?
C3F8.
Ah, C3F8.
Actually, there is another aspect of choosing the tamponade, and it is the type of patients you treat from where they are. If they need to travel, you cannot use gas. And the other thing is university or private setting, because in the university you have chance to repeat your surgery without additional co-payment from the patient. In private setting, you will lose your patients because the referring doctors will say, oh, he uses gas and everything is a mess. I will send to another center. This is the sad truth.
Yeah, I think that's the real side of practice, right? Yes, you're right.
I don't use C3F8 anymore for many years. What is the advantage to use C3F8? Because, you know, at the end, if the retina stays there for 1 week, I think it will stay there. If it fails, it will fail. You know, I don't know the main advantage of C3F8. At the end, it takes a long time to disappear. And I don't use it.
I think the only thing really here is what, again, the PVR cycle. Usually, like primary detachment, I would use SF6. But I totally agree with you.
Yeah, but
either it will stay flat or not. This is here about 3 weeks after, 3 to 4 weeks after.
That's great.
Yeah. So in this case, I think it's really the sickle cell anemia, trying to avoid a buckle. And then that's how it went. So I have a few questions from the audience here. If you are doing a primary retinal detachment and there is some stiffness in the retina, so maybe not really like true PVR-C, but maybe PVR-B, would you do something different? Let's say you're doing a vitrectomy for primary retinal detachment. So Dr. Fayyad, let's start with you. So what you do, if you're gonna, I know that you try to buckle, but if not, then you will do a vitrectomy. How do you do your vitrectomy for primary retinal detachment? Dr. Fayyad?
Faisal?
If there is some stiffness, I start my vitrectomy by placing a scleral buckle.
Okay, so combined encirclement, right?
Absolutely, absolutely.
Right,
because,
right.
You know, it's so easy to cut the retina, but it's not the way to go. I mean, you have to place a scleral buckle to be a conservative surgeon and flatten the retina over the buckle if there is some stiffness. This will be balanced with the scleral buckle. There won't be any problem.
And Carlos, do you combine as well?
Absolutely. Buckle bead and staining to see if there is any immature membrane. If I see something, I would remove the ILM in this case.
Okay.
That's in gas.
Okay, and then gas. And what type of gas? SF6?
No, C3, SF6, 20%. 20%.
Right. Okay, and if there's no stiffness, do you also, all detachment get combined buckle and vitrectomy, or if there's no stiffness, you just do a vitrectomy?
Me?
Yeah.
Oh, buckle vitrectomy.
All buckle vitrectomy.
I deal with the buckle vitrectomy. This is 1 hour surgery, you know, you're used to it, you know.
Okay.
You know, sometimes, sometimes you face that there is a partial retinal detachment, just upper retinal detachment, bolus retinal detachment, and you can see where the holes are. I mean, the inferior retina is attached. In these cases, I don't scleral buckle. I don't put a scleral buckle.
No, sure.
I just go for primary vitrectomy and gas or air tamponade. This is it. I mean, a scleral buckle, I mean, there is not such surgery that is one size fits all. I tailor the surgery for each patient.
Very nice. Gianpaolo, would you do anything different in this situation?
Well, no. Essentially, I think these are the guidelines which we all have in mind, and the fact is that each patient is individual.
Right. And Lucan, do you do combined buccal vitrectomy? for primary?
No, I just don't like the idea to relieve the traction from the vitreous, which is the primary reason, by bringing the retina to the vitreous. I
Right.
simply remove the vitreous. So this is a philosophical thing to me,
Yeah.
actually.
No, and I think
Very
again, it's
philosophical.
the gray areas of retina. And Noor, do you combine buccal and vitrectomy?
For primary vitrectomy, usually no, because in this
Right.
era we are able to complete vitrectomy. Only maybe the pediatric patients that I cannot make a complete vitrectomy, we can combine with the buccal.
Right. Okay. Well, last question here, really, and thank you so much for staying with us. So there's a school of thought that actually maybe if you do a retinectomy and you're going to put oil, don't do any laser. Because what happens when you put laser is that you tag the retina down, so you're not giving the retina a leeway to retract. So don't do any laser, give the retina leeway to retract a bit, and then before putting the oil, just come and laser, because if you're a believer in tamponade, actually the laser is not that important if you have oil still in. So I wonder, what do you think about this? So Carlos, I see you nodding. What do you think about that?
I absolutely do laser, my friend. These PVR cases are so complex. I always do laser. The idea is fine, but
Yeah, me too.
You
Yeah,
think it's too philosophical, right?
I may be wrong, but I'd rather sleep at night.
Right.
yeah. You know what, Ahmad? Often these patients, if it's a long surgery, you have cyclitic membrane, and you can do laser for a while.
Right.
And I mean, it's much wiser to do the laser right away,
Okay.
unless you don't have a laser machine inside your operating room. But
Yeah.
if you have a laser machine in your operating room, it is mandatory.
Right. Noor, too philosophical.
Too philosophical.
Right.
Pexy, we have the name, so we have to pexy it in the surgery. But how I do the laser, not so strong power, not very edge of the retinectomy, because
Right.
it's still slippage. So I just place one spot at least at the edge.
To give it a bit to slip, right?
A bit scattered also. And
Right.
as I know in one of the cases, especially in the pediatrics, I do, for example, 360 degrees, I do something like a scattered laser even to the mid periphery also, like in the diabetic patients. I believe somehow that those areas, if you do the peeling good with vitrectomy, those areas also help.
Right. Lucan, final question for you. Do you think this is too philosophical, or do you see this like or would you buy that thought, or no?
For me, it was already said by Dr. Ginny. We need to do all we can do in the first surgery. So
Right.
laser should be done in the surgery, and everything should be done there. And I agree with Dr. Akar. The scattered laser, not tight spots, a little bit more aside in order to leave a space to maneuver of the retina.
Okay, so I think the thought is there. You give time, you give a bit for the retina to slippage, whether you don't laser or laser with spaces. But it's a thought really coming from the Netherlands mainly. Well, last question for sure from Barbara. When is it a time to stop? So the patient had multiple surgery, now is becoming a social embarrassment. And when will you say, well, I think we should stop? Let's say that the vision in the other eye is good. So how do you approach that? Dr. Fayyad, how would you approach that?
When I decide to stop, I send my patient to my colleague.
Yeah. So I think that's very wise. So you give them a second opinion, right?
Yeah, second opinion. Opinion.
That's very wise. And Noor?
It depends on the patient, of course. I mean, sometimes patient can also expect the surgery. Having a second or a third opinion is a very nice idea. As Faisal showed us the totally complete funnel, and it is opened, sometimes also some cases surprise us during the surgery. So, I mean, if it is light negative, of course, if it is light positive, and you do the surgery, and you are tired at the end, and there's no hope for it, so I stop, of course.
No, let's say this patient had under you and had 4 surgery.
Okay.
And you think there's maybe a potential to try to enlarge the retinectomy more? Would you say let's go for the 5th surgery?
Yes. If I believe that there's a healing I suggest, yes.
Okay. And Carlos, let's just make it easy. A patient had 4 surgeries.
Very clear to me. Hypotony and corneal opacification.
So you would not.
Yeah.
So you would keep going, or you would not?
No. Hypotony and corneal opacification, I stop.
Otherwise, you keep going.
Yeah, sure.
Okay. And you can.
The first one is hypotony, then function. If there is no light perception, why we should go.
Sure, of course.
And the other thing, if there is no retina remnant, I wouldn't go. And the other thing is there are some golden deposits under the retina. When I see this, it is doomed. Like exudates, but they are like golden. When you see that under the retina, it is doomed.
Okay. And Gianpaolo, I'm sure that all the cases flattened in your hand was the first surgery. So, but we'll ask you that question.
I think we have to think second best being cosmetic. So if function is not there, you have to try and somehow think ahead and see how this person is going to fit in society. A lot of times these are young patients that have issues with girls, with friends, and so forth. So cosmetic preservation of the eye, if possible, is very important.
Right. Just from my side, to play the devil advocate, there's also something very rare you need to take in the equation, which is sympathetic ophthalmia, especially when there's no vision is expected or very, very limited. Because actually the most common cause of sympathetic ophthalmia now, which is really still very rare, is vitreoretinal surgery.
Yes.
So with that being said, maybe we're not finishing on a very optimistic note, but just to balance everything. But Gianpaolo, I'll leave you to conclude.
I think it's been quite interesting. As expected, we have some different views, but in general, I think the steps that were laid out by each one of you were quite clear. And unfortunately, not much has been done in progressing in treating this disease, as I've shown with that old video of mine. We can only hope that more research will be done. And this is where the younger generations come in. And this is why we have meetings. This is why we confront each other. And I hope we can do so physically in the near future. Thank you.
Well, thank you so much. I would like to really thank our panelists so much, especially Dr. Fayyad and Dr. Akar and Dr. Mishev, because it's really late. And also, of course, our guest speaker and our friend, Dr. Mathieu. Thank you so much, all. And my friend and co-moderator, Dr. G. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Okay.
Nice.
Learning and sharing. Thank you.
Have a rest. Have a rest.
Thank you. Take care.
Thank you.
See you soon.
See you.
Yes. See you soon. We're off. We're off.